Good afternoon, everyone. This is Julie. Thanks for joining us today. I'm going to turn the webcam on. You can see Dr. Cox. Whoops, I just turned it off. So that means I have to restart it, but it will be relatively quick. There he is. So he's here. This has been an exciting one. A couple questions that came through emails and different venues kind of prompted him to want to review this information, update it with some newer stuff, and talk about this disc and chemical irritation and what role it does play in back pain. So thanks for joining us today. If you didn't see my notes in the chat box, be sure that you know that you can download the notes of all the slides today. He's got about 107 slides. Well, a lot of them are images too, so he should go through those pretty quickly. But you can download those through the handouts tab. And I can also give you a link in the follow-up email later if you need that. So get the notes there. If you have any questions, add those to the questions panel, and I will interject those when it's appropriate, when he has a quiet moment or whatever. I'll be sure and ask him those questions. And midway through, we'll switch over to the table so that you can see him do a technique demo toward the end. I'm not sure what point that will be, but it'll be midway through, so you'll see him show technique as well as the forces on the force table. So Dr. Cox, I'll turn it over to you. He is the lover of all things spine, devoted reader every day, and emailer of this stuff, and I get copied on it all. So enjoy today's webinar. Dr. Cox.
Thank you. Thank you for studying with me today. I think we look at neurocompression, which is historic in our profession, but the neuroinflammation is equally important. So I'd like to share some of these concepts clinically with you. Let's always begin, and you must give credit to clinical biomechanics of the spine by White and Punjabi with this slide. And just a couple points briefly, okay? The entire disc is pain sensitive. It is supplied by the sinovertebral nerve here. It's supplied by the gray rami communicantes of the sympathetic ganglion chain. The dorsal ramus innervates the periosteum of bone, the ligamentum flavum, the faucet capsule. So it's a very pain-sensitive structure. I'd ask you to also remember as we proceed that the dorsal root ganglion is 3 times larger than the combination of the less than 12 millimeter long ventral and dorsal nerve roots. It is big. And how big is it? Well, at L5S1, some people say it measures up to 9 to 11 millimeters, filling 50% of the osteoligamentous canal. You and I live to destenose to a large extent the dorsal root ganglion, and not just destenose, but to de-inflame as we will proceed. This paper pointed out, and Norm Kettner sent me this from Logan last April, the aging changes of the intervertebral disc finds that there's an increased innervation of the intervertebral disc, which leads to discogenic back pain. The 3 common things that you and I deal with in a chemical inflammatory nature of discal degeneration and spinal stenosis, one of them being the perivascular nerves, which we will look at, the nerve supplying the blood vessels to the nerve itself. Now you got to go deep here to think about this. Then we think about the sensory nerves independent of blood vessels and the mechanoreceptors type 1, 2, and 3, touch, temperature, and control. We must remember that neural ingrowth into the nucleus of the disc takes place with disc degeneration. The general trend is that the inner 2/3 of the annulus fibrosus become innervated with pain-sensitive fibers, which are what? Largely sympathetic gray rami communicantes like this, where if we have a normal disc, the nerve supply of the inner nucleus is not great. The outer annulus is. But with discal degeneration and the aging process, you can see here that all of the chemical inflammation creeps into the nucleus itself the nucleus begins to be more and more heavily innervated with sympathetic nerves. Yes, even the DRG itself sprouts nerves directly into the intervertebral disc. So that when you and I read Kuslich, for example, Orthopedic Clinics in North America, 22.2, he said the most pain-sensitive tissue in the low back is what? The intervertebral disc. Well, when you see this take place, and you see that the vertebral end plates become impermeable to imbibition of fluids from the cancellous vertebral bone, then it becomes more of a dry, fibrotic, inert substance. MRI shows that this dorsal root ganglion, its location, can be divided into 3 types. In the intervertebral foramen, 81%. Inside the intervertebral foramen, 16%, and extraforaminal, almost 1%. And no one treats long until you learn that extraforaminal prolapse with chemical inflammation is a very, very difficult case to treat. I want to mention to you 2 things which are, I would assume, maybe new to you. They're new to me, and I try to keep up with it. But it's about diffusion tensor imaging and its counterpart of tensor diffusion imaging. Both of these techniques are designed to measure and assess nerve fibers within the intervertebral disc. And remember, it is said in this study that the brain, the DRG is the brain, that it could actually receive an afferent impulse, process it, and create an efferent response without a rostral transmission to the brain. But even more important is the fact that the DRG is a source of peptide inflammatory agents, such as substance P, calcitonin gene-related peptide, the vasoactive peptides. And remember, these cause vasodilatation and inflammation at the outset. But with chronic inflammation, sympathetic fibers will become predominant to these tissues, and we develop what? Ischemic hypoxia of the nerve. So the critical role of the DRG in the maintenance of chronic pain has been largely overlooked in the past, and that's what these papers are telling us. We're going to look more closely at chemical inflammation of the DRG. This paper and these papers, you can ferret them out if you want. But this one was the original paper by Jenkins et al. And get the point. In chronic pain, the DRG, the disc itself, the perivascular nerve supply of the nerve becomes predominantly autonomic sympathetic nerves, which create, when inflamed, ischemic hypoxia. So let's remember that as we proceed. The intervertebral discs are innervated by the DRG with degeneration. They sprout nerves right into the disc, as this paper points out. And this nerve growth into the nucleus of diseased discs is a cause of chronic low back pain. The sympathetic nervous system is seen to be a strong association between hypersympathetic atonia of the nerve and vessels with disability that accompanies low back pain. Without any significant communication with other regions of the spinal gray matter, this paper is pointing out that the dorsal root ganglion is like a brain in itself, having the ability to accept an afferent impulse, act upon it at that level of the DRG, and even perhaps within the substantia gelatinosa, to produce an efferent pain-relieving impulse that innervates those painful structures. Now, just remember that the dorsal horn, the dorsal root ganglion, is one level of action where touch, temperature, and pressure will first be delivered to the sensory nervous system. When that tissue gets to the substantia gelatinosa within the posterior lateral horn of the gray matter, that's where the actual drowning out of the type 4 nociceptor takes place by the stimulation of what you and I do as manipulating physicians by stimulating touch, temperature, and pressure. They actually will block the transmission of a pain impulse to the substantia gelatinosa of Rolando and then rostrally transmitted to the somatosensory cortex of the brain. Nikolai Bogduk, a great name, he actually put in Journal of Manual Medicine, Volume 5, in discussing disc pain, he made this comment that actually it is tantalizingly seductive, and I'm using his terms, they're not my terms, but he interprets back strain and sprain, ligament strain, and mechanical back pain, which we so ugly call, in my opinion, non-specific low back pain, if there is such a thing, which I don't think there is. But what he really says is it really is sprain and tearing, whether they be circumferential or radial, of the annular fibers of the disc, which are by some extremely pain sensitive. Moon wrote this paper, and you can look these up, but the essence of it is that there is nerve ingrowth, growth of new blood vessels, which are surrounded by sympathetic nerves, thought to be one of the major causes of discogenic low back pain. That can result in sclerotogenous pain, radiating to the buttock, the lower extremity, usually not below the knee, unless it creates chemical inflammation of the DRG or the nerve root, resulting in full sciatic radiculopathy. So note here, tumor necrosis factor is one of the big pro-inflammatory cytokines that irritate nerve roots and dorsal root ganglion to create sciatic radiculopathy and low back pain. This is just an interesting paper by Stefanikis that points out that these tears of the peripheral annulus contain 36 to 50% less proteoglycans. What does that mean? It means that as discs degenerate, they lose their mucopolysaccharide proteoglycan structure called chondroitin sulfate. Chondroitin sulfate is that chemical that has the ability to imbibe fluids to well over 80% of its own volume. So as we lose this chemical, this proteoglycan, and this paper so nicely points out that they are conducive to ingrowth. As you lose the chemical makeup of chondroitin in the disc, there's an ingrowth of nerves and blood vessels into that disc, so that these annular fissures, the high intensity zones that you and I report on our MRI studies quite frequently, are really chemical inflammatory changes of the annulus fibrosus of the disc. And I want to point out to you, I give you these references so that you can go back and check them or use them. You can double check what we're studying today so that you feel very, very comfortable with commenting about what we know today. High mechanical stress, weight bearing. It is known that the intervertebral disc cells will then begin to produce cytokines. And what are cytokines? Cytokines are inflammatory chemicals produced primarily by macrophage type 1. So that when you have a tear of an annulus and the macrophages neovascularize that tissue, that those macrophages will produce not only nerve ingrowth into the disc, but also pro-inflammatory, chemical inflammatory mediators that you see on the screen here that we call tumor necrosis factor alpha, interleukin 1/6, interleukin 8, interleukin 15. These are the chemicals that, at least as I read this, and I leave it to your erudite study, these are the chemicals that you and I must contend with in treating low back, sclerotogenous, and radicular component pain. When we get done, you will be excited about some of the future concepts and proofs that our profession can do to this degree. Here's Rizbud, who talked about the cytokines and chemokine. A chemokine is a special type of a cytokine. It is very inflammatory, and it causes intervertebral disc degeneration. It causes back, neck, and radicular pain. Neurogenic factors coming both from disc degeneration, the immune cells, and the expression of these chemical inflammatory cytokines in the dorsal root ganglion itself, the brain of the low back, are a big cause of back and radicular pain that you and I as clinicians deal with every day in clinical practice. At the end of this, I'd like to share with you ultrasound studies of the difference between 1 to 2 pounds versus 6 to 8 pounds of decompression of these tissues, and how you and I know by the work of Mosgood, Isner Horabetty, and I don't mean to just throw names at you because they're all in didactics that we've studied together. Even Ralph Gay at Mayo. These people show you that in pain, you and I deal with pain and disability all day. Pain and disability. Pain is relieved at low force distraction. As pain diminishes, we increase the forces, which I will share with you. And that's what relieves disability and returns activities of daily living. Those chemokines that we talked about, they actually respond to inflammation to create homeostasis within the disc itself. And it's called innate immunity. That is, we balance pro and anti. That is, type 1 macrophage is pro-inflammatory. Type 2 macrophages, which produce interleukin 10, for example, are anti-inflammatory. And it is the balance of these types of cytokines that creates what this paper is talking about as the homeostasis within the neural complex. We suggest in this paper that pro-inflammatory cytokines produced by the interaction of intervertebral nuclear cells and macrophages, which we've been talking about, may be linked to the cause of the pain and degeneration in intervertebral disc herniation. So some of these papers, my colleague, you may well want in your library, or to even, I'm weird, but I share these things with patients. Some of them enjoy it. Some of them say TMI, too much information, but some people appreciate that. Here was Vernon. What's different about spinal pain? Well, pain afferents from the dorsal horn and the deep, and basically the disc and the paravertebral muscles of the spine together both produce afferent nociception, which carries to the dorsal root ganglion and then to the posterolateral gray matter of the substantia gelatinosa. Remember, the disc has a dual nerve supply. Anterior sympathetic, posterior is sinovertebral. I offer to you, these are what type of autonomic nervous system? Sympathetics. So does stress increase back pain? Oh yeah. It's known that depression and stress increase back pain. Why? Because it stimulates the sympathetic nerves. The HPA axis becomes effective. The noradrenaline, norepinephrine produces, aggravates what? Causing neuroconstriction of the blood supply to the nerve, resulting in ischemic hypoxia, which results in a nerve feeling what? Numbness. Okay. This is a beautiful slide. I did this at National with Kai-Sung Roh, a MD, PhD neuroanatomist who is now deceased. I walked into the lab one day and Dr. Roh has this specimen he's dissecting. I said, Dr. Roh, what are you doing? And this is at homecoming. Everybody else is out partying, and here's Dr. Roh in the lab dissecting out the sensory innervation of the intervertebral disc. I said to him, what are you doing, Dr. Roh? And he said to me, I'm dissecting out the sensory innervation of the vertebral column and the intervertebral disc. This slide belongs on the ceiling of your bedroom, doctor, in my opinion. These are all the nerves from the gray rami communicantes that supply the intervertebral disc. What a beautiful piece of dissection. In the book, Dr. Kramer, chief of research at National, and I wrote a eulogy of Dr. Roh with this picture. What a beautiful man, a great anatomist. So Kuslitz wrote, and I referred to this orthopedic clinic 22 too, the disc is the most pain-sensitive tissue in the spine. I'd ask you to remember, my colleague, that the spinal cord, the cauda equina, the exiting nerve roots are all surrounded with what? Arteries and nerves. So the ascending and descending arteries and veins form an anastomosis around the cord, follow the nerve out to about halfway through the DRG. The nerve, the blood supply becomes buried within the interstices of the nerve. But we know here, and just follow, this is Takahashi, spine 2419, okay? If I put 20 millimeters of pressure on these nerves, roots or DRG, it results in what feeling in the nerve? Numbness. What if I increase that pressure by the work of Takahashi et al.? Beautiful paper. To 60 millimeters, now that patient will begin to feel not just numbness from ischemia, but pain due to nociception. Reflexes will be diminished. The sensory innervation will become numbness to pain that's so bad that sometimes one can't walk, one can't sleep at night, and full radicular component with motor weakness will be seen. Do you ever stop to realize, my colleague, you and I live here? You may not agree with me, but I'm just saying that. This is where you and I function as spine specialists, right here. You get below 20 millimeters and you may feel good. You go out and dig in the garden or do something and you increase that pressure to 30, and all at once you've got numbness and pain. This is where the action is. Remember Takahashi. Just remember that
an annular tear, say on the right side, could you get left leg pain?
with what? Chemical leak. Let me cover that. I'm going to cover it. Excellent question. Excellent. You can have a chemical leak on the right, leak over, affect the nerve roots on the opposite side and have contralateral pain to an ipsilateral disc herniation. May I cover that shortly? Just realize here, sympathetic gangliated chain, intervertebral disc, well supplied by the gray rami, and back here, the sinovertebral nerve. This is the world you and I live in right here. These are the gray rami communicantes here. The intervertebral disc dorsal root ganglion, again, where you and I function to do two things, to reduce stenotic compression and lower chemical inflammation. Remember that the blood supply of a nerve is 70% from cerebrospinal fluid, 30% by blood supply. We just covered the compressive forces by the work of Takahashi that cause ischemic hypoxia. Chemical radiculitis, which is what that question was about, caused by cytokines, phospholipase A2 from the disc and the facet joint. Remember ischemia. The nervous system is a hog. Did you know that 20% of the available oxygen coming out of the heart goes to that 2% of body mass known as the nervous system? So when you cut down the vascular supply, you've interfered with the metabolic needs of that nerve. During straight leg raise, why is it positive? Because we are further causing dural irritation, dural compression, aggravating chemical inflammation of the dorsal root ganglion. Let me look with you, if you would, at deep. When we treat a spine, these exciting things are going through our mind. What is the vascular system of the nerve itself? Well, nitric oxide is involved in radiculopathy. Nitric oxide may play a role in development of bladder activity, so that many people, when we are talking about the pudendal plexus and the chemical or the mechanical compression of same, isn't it very common that cystitis, oophoritis, salpingitis have been documented by people like Leonard Hurlin as being due to neural compression due to disc herniation? The rat lumbar DRG is supplied with autonomic nerves. Please note that. The dorsal root ganglion is supplied with sympathetic nerves. It has a very comprehensive perivascular, adreneric, sympathetic, cholinergic, parasympathetic innervation. Let's look at that. So these autonomic nerves supply the nerve root. And here, my colleague, we are looking at nerve fibers surrounding the nerve itself. But here we're looking at the vasculature of that nerve. Yes, you can even see an indentation where a artery indents a nerve. It's like a spider web, like a can of worms surrounding these vessels to supply them with nutrients. I think sometimes I never appreciated until I read this research about the intimacy of the autonomic nervous system supplying the blood vessels that supply the nerve itself. Okay. So when we look at this, adreneric and cholinergic, sympathetic, parasympathetic. Sympathetic nerves are the sympathetic nerves, cholinergic, parasympathetic. I don't know how many of you, and it's not the intent of this presentation, to go into vagal stimulation, whether it be at the jugular frame and C4 or at the celiac plexus of the abdomen. But when we stimulate parasympathetics, we bring about vasodilatation, relaxation, and calmness. When we stimulate sympathetics, what do we produce? Vasoconstriction, irritation, stress, and tension. This just shows you the nerves that are supplying those vessels, supplying the nerves themselves. Adreneric, cholinergic, you can read these. Do we live in a hypersympathetic atonic world? Yeah. Fight or flight, as opposed to rest and digestion, which are cholinergic. So why do we stimulate the vagus nerve when we treat? That's again not the purpose of this, but is to create parasympathetic to drown out sympathetic. We live in a very hyper world. We create microvasculitis when we have neural compression. The chemical inflammatory changes. Let's look a little closer at this, may we? If I look at discography, And I realize both the pros and the cons of it, so do you. But it has been used classically. And Greenspan's article back here in Applied Radiology back in 1993, when it really reached somewhat of a threshold, right? Pointed out that it was done, you had 4 months of pain, you were contemplating surgery. Nothing showed on MR. They were all normal and they were unresponsive to conservative care. Well, just keep in mind that Osti pointed this out in the Journal of Bone and Joint Surgery, that MRI misses early disc degeneration, causing low back pain. 1 or more disc protrusions were identified in 73% of scans performed sitting, 50% performed in recumbent. Incidentally, at our clinic, when we order x-rays and even MRIs, we like them done standing. What percent of 9-year-olds, I have the paper, it may not be here, but if you yell for the reference, I got it. What percent of 9-year-olds show disc protrusions? 73%. 73%. Now, I know you're sitting there and saying, oh, Jim, that's awfully high. Well, what percent of teenagers have back pain? 58%. So you and I are dealing with the end results, you know, when we get them 25, 30 years older, my age, in the 80s. It all started where? Way back there in the early years, even the adolescent years of life. So if this is a discogram, here's a disc filled with dye. Here you see a disc which is a type 1 tear, an annular tear with nuclear material escape. The closer that nuclear material moves to the periphery, the more pain sensitive our patient becomes. Until here with discography, you see it escaping posterolaterally. We can even see that it leaks into the vertebral canal. And with retrolisthesis and more imbalance of the posterior longitudinal ligament and the disc itself, it leaks into the canal. It looks like someone took a nucleus, which is like the yolk of an egg, busted it, let it spread out, and then fried it. How was that? Disc degeneration. Do discs ever leak anteriorly? Well, doctor, you've seen this. You look at your MRIs and you see nuclear material escaping to the anterior, superior, or inferior end plate of the disc. Here's a completely retrolisthesis due to instability of the disc, allowing that posterior movement. To give you an example, looks like a pretty normal looking disc, but you fill it with dye and it looks like it's leaking back into the vertebral canal. But what's it really doing? It's leaking laterally, sneaking in the back door to chemically inflame. What's here? The dorsal root ganglia. So that's what percent did we say of discs are foraminal? Well, well over 80% of them. So here, the leaking material comes back, leaks onto the DRG. Here we have a chemical inflammation, cytokine, pro-inflammatory, macrophage production, causing radicular pain. This patient may have what? No back pain, just radicular pain. You must know that the difference between, I gotta be careful I say this. You really want to understand that kind of thing to diagnose adequately. A high prevalence of disrupted annulus was found associated with tearing of the nucleus between the annular layers toward the posterolateral and posterior regions. Looks like this, doctor. Nothing like a picture. Here are the circumferential tears of the annulus fibrosus. See how they begin to tear? And then what forms? Then we have a radial tear, which allows the escape of the nuclear material through this tear, which if it is contained is called an extruded disc. If it comes to lie within the canal, is called a sequestered or a free fragment of disc. And as it tears through here, it may cause very little back, if any. but pure chemical inflammatory sciatic radiculopathy. Let me ask you a question. Have you ever noticed that sometimes the most challenging cases we treat are the ones that have no back pain, just what? Leg pain, sciatica. Pretty good indication of chemical inflammation. And yet this paper comes out by Amar pointing out that there's really no significant correlation between the pathology of the prolapsed disc and clinical findings. You and I have read many papers on this that you can't look at an MRI and tell whether the patient has any symptoms or not. We must correlate the clinical finding with diagnostic imaging. And again, here's Corner in Spine Journal writing about these chemical inflammatory agents. What are they again? Interleukin-1, tumor necrosis factor alpha, interleukin-6, interleukin-88, and not shown here is interleukin-18. They create neuroinflammation. They create chemical inflammation of the nerve and pro-inflammatory cytokines. So when these chemicals increase, especially with free fragments of nuclear material, then sciatica becomes increasingly severe. Kang wrote this paper that is the increased expression of these inflammatory cytokines in diseased cervical discs that play a role in discogenic back pain. When I read those papers, it tells me that I need to be aware of lowering chemical inflammatory cytokines as well as lowering neural compression as seen by the work of Takahashi. These are some of the chemicals. Herniated discs produce nitric oxide, interleukin-6. All of these chemicals that create chemical inflammation. Prostaglandin E2 is a known neuroinflammatory predator that causes sciatic pain. We also, at the same time that we see these disc changes causing radiculopathy, we also have evidence of paravertebral muscle changes with tumor necrosis factor expression that parallels disc degeneration with what? Muscular degeneration, and especially in what muscle group? The rotatories of the lumbar spine, called the multifidi. Multifidi are the most common fat degeneration muscle in the low back. They demand strengthening, and how we treat them, as I'll share with you shortly. What is it that makes what you and I do successful? You read this paper by Wong et al., and I'd ask you to note that Greg Kawchek is on this paper as well. Increased range of motion. These people showed that with a single chiropractic manipulation, the patient who received the greatest increase in range of motion showed statistically significant decreases in pain. And look what else this paper showed. Increase in the multifidus muscle thickness, which was found to be sustained for 7 days. Well, I'll tell you, doctor, when you and I treat a spine, these papers must be in our mind. I'm thinking about the multifidus. I'm lowering chemical inflammation. I'm lowering neural compression. All these things that we do as chiropractors, which are well shown in research today. This paper, Radiculopathy, is a result of two things: mechanical compression and neural inflammation. You and I have no choice but to address both of these issues when we are treating macrophage invasion of disc tissue causing neural inflammation. If you put nuclear material, get this, doctor, if you take a dorsal root ganglion, put nucleus pulposus tissue on it, what happens? It causes selective cell death, causes apoptosis within the DRG. Tumor necrosis factor put on the DRG shows these changes within the nuclei within 24 hours. To me, that paper alone is a reason for us to be here today. Silva says that decreased expression of catabolic and anabolic genes clear back into the genetics of the disc are seen under inflammatory and mechanical stimulation of the DRG or a nerve. Okay. Intervertebral disc degeneration is accompanied by elevated levels of these cytokines. What causes discogenic pain? It is the neural compression and the chemical inflammation by tumor necrosis factor alpha, interleukin 1 and 6. The macrophages invade the dorsal root ganglion after nuclear contact to produce these pro-inflammatory chemicals. And if I could just take you through this algorithm, please. What is it that happens in this chemical inflammation? Well, the pain is modulated when arachidonic acid is converted into thromboxane A2, which is then converted into leukotriene B4. And now the macrophage enter, we have the production of cytokines such as the interleukins, the tumor necrosis factor, the chemokines, all which produce what? Chemical inflammation. Isn't that a beautiful thing? So when we treat, these are the things that go through our mind as we are treating, as we're going to share here shortly. Leukotriene B4 is a potent inflammatory mediator derived from arachidonic acid. Constriction of a sciatic nerve increases, now follow this, increases galvanin production in the dorsal root ganglion. It modulates under chronic irritation, neuropathic pain. So the degree of galvanin production varies directly with the amount of neural constriction. You shut off the blood flow, you develop greater amounts of galvanin, glutamic acid, and disc compression induces persistent nerve injury and regeneration of afferent fibers. The results of this study by Ur show that increased neuropathic pain, and 37% statistically of the people that you and I treat have neuropathic pain. It is a component in sciatica patients associated with elevated levels of depression, anxiety, alexithymia. You and I know that depression and stress increase pain. Why? Because of the HPA axis, the production of adrenaline, noradrenaline in the adrenal glands, creating hypersympathetic atonia, creating ischemic hypoxia, diminishing the function of the parasympathetic nerves. Among adults with chronic low back pain, what is pushed today? Mindfulness-based stress reduction. You and I are great at this. We try to put people at ease, tell them we're going to get you well. You know, we may even send them to a mindfulness-based stress class, which are about what, 8 weeks? 8 weeks long. And as you reduce stress, stress is like gas on a fire of hypersympathetic atonia. There's consistent evidence that get this, that neuropathic pain present in chronic low back pain in 37% of the cases and 41% of soft tissue irritation. Low back pain is a highly prevalent condition in middle-aged people. And when it was analyzed, the participants less than 40 years of age, anxiety. Get that? I didn't write this paper, they wrote it. That the only significant variable in these 40-year-old people or less was anxiety. We live in a very stress-filled society. High intensity zones, not designed to do that today, but when you and I see hyperintensity within the annular fibers of the peripheral disc, posterior and posterolaterally, those are chemical inflammatory signs. Those are what create back pain and ultimately disability. The reduction of the expression of gamma aminobutyric acid receptors in the substantia latosa neurons are observed after chronic constriction. What does that mean? Well, in the brain, the synapse reproduce glutamic acid, glutamate. A byproduct, one of the products of that is gamma aminobutyric acid, which suppresses the function of galanin. When you have chronic constriction, what do we have? We have a reduction in the production of gamma aminobutyric acid, which heightens the pain element. Remember that glutamate produced in the brain stimulates neural transmission. It also produces gamma aminobutyric acid, which inhibits neural transmission. Now, if you carry yourself a little further, you could say that when we treat, when we relax the sympathetics, we stimulate circulation, we decompress intervertebral disc pressure, we increase foraminal area, we increase disc space height, and we stimulate afferentation by physiological range of motion under distraction of facet joints. That these are all things that can reduce the stress and lower the production of glutamate and gamma aminobutyric acid. So in essence, two things cause the conditions you and I see. One, mechanical compression. Second, nuclear material inflammation. Both of them cause intraneural inflammation. The first finding at about 20 millimeters of compression, ischemic hypoxia. We increase that, we develop intraneural edema. If that isn't reversed, we develop fibrosis. And if that isn't reversed, we even develop demyelination of nerves. All of these followed with motor weakness, sensory deficit, and pain. So one last thought for you. The cell lining of a cell, a nerve cell, a disc cell, is surrounded with a membrane that contains receptors. And those receptors, they will block pain impulses coming in. They're called ligands. When they meet a receptor, they can block that ligand, that chemical inflammatory agent, from entering the disc cell. Now, many diseases are treated that way. That's called immunotherapy. And an example of that is that chronic constriction of a nerve causes greater imbibition of pain into the nerve. And these are called myosin activated protein kinases. They're receptors within the cell wall. And when you and I treat, all of these chemical inflammatory agents, these cytokines that we talk about, pass through the cell wall into the nucleus of the disc. What is one of the things that we do to reverse disc degeneration? We give people chondroitin sulfate. It's a compound used in treating osteoarthritis, joint pain, and allodynia. It attenuates and blocks allodynia by inhibiting the receptors in the cell wall of the disc and white fibrocartilage. So here we use chondroitin sulfate. This is chondroitin sulfate. I first started using this in 1966 when I first got really into treating back pain. But it is the treatment of osteoarthritis and joint pain. We also put these people on a very short course of turmeric root. That is curcumin with Boswellia serrata, white willow bark, devil's claw, and quercetin. They are anti-inflammatory. So we put our people on anti-inflammatory disc and joint relief. We put them on chondroitin sulfate to supply the disc with the building block of white fibrocartilage. Before we go to the instrument, I'd like to leave you with this paper for your consideration of the future. This is research that was reported in Chiropractic Manual Therapy, January 2021, Volume 8, by Injayan, Triano. These Injayans are husband and wife at CMCC. The name of the paper is The Effect of Spinal Manipulative Therapy on the Inflammatory Mediators in Patients with Nonspecific Low Back Pain, a non-randomized controlled clinical trial. What did they find? They found that a short course of spinal manipulative therapy of nonspecific low back pain resulted in significant, albeit limited and diverse alterations in the production of several of the mediators investigated in this study. This exploratory study highlights the potential of spinal manipulation to modulate the production of inflammatory components in acute and chronic low back pain patients, suggesting a need for further randomized controlled trials. In these papers, they were looking at a reduction of interleukin-6 and an increase of interleukin-2 following spinal manipulation. Here we're looking at, therefore, some future, which will go to the instrument and share, about not only reducing neural compression, now lowering chemical inflammation. And I leave you with this thought that there are even papers out now of urine tests to check the levels of tumor necrosis factor alpha. Could you imagine a urine test that you could do before, during, and following a course of care? I'll go to the instrument now.
Let's do two questions real quick. One was, will an annular tear in the absence of a bulge or herniation produce antalgic lean?
Yeah, we have chemical inflammation, but you find if you go to, in my textbook, or you go to Punjabi and White's Clinical Biomechanics of the Spine, you see beautiful, beautiful presentations of disc protrusions contacting the nerve and DRG, causing the patient to either lean away from or into, or not lean at all, just stand in a frozen flexed position. These are primarily either protruding or extruded discs in which a patient seeks some form of sciatic scoliosis to disengage the neural compression of the annular bulge from the sensitive, which we just covered, DRG and nerve roots. Next question.
How far into the disc do nerves actually infiltrate in degeneration? Do they go all throughout or just partway into the
all the way in, depending upon, and I showed you the slide earlier, they can go all the way to the interstices of the nucleus. Isn't it interesting, if you look back when you were in school, what were you taught? That the only nerve supply of a disc was the outer annular fibers. I can remember lectures many years ago in which we were taught, well, don't worry about these discs and these tears because it's asensitive tissue. You know, isn't that terrible? We didn't know any better. Now we know that these discs are extremely pain sensitive. And a tear, a chemical inflammation, the high intensity zones are certainly creating what? Hypersympathetic innervation, making that area extremely sensitive to movement, lifting, intradiscal pressure increase. Yeah, they can grow according to people. And I'd urge you to read the paper by Moon that you'll get. You can have all my notes. Moon, M-O-N, read that paper. As we mentioned earlier about the work of Isner Horabeti,
Mazud, Alexander, Gay. Low force is where we begin for pain. And when you and I, the more pain a patient's in, the more gentle we start. As pain diminishes, we increase our force of distraction to reduce disability. So we follow certain subjective evaluators. We look at the number of visits or the degree of pain, O to 10, O to 100. We look at the Oswestry Disability Index. What is considered minimal clinical improvement? Well, 20% reduction in pain or disability is considered a good clinical outcome, meaning that the technique used was worthy of being used. I'd like to share with you one of the things that's evolving with our ultrasound studies at Kaiser University College of Chiropractic Medicine, headed up by Ram Godavalli and Ralph Cruz. And that is, we are measuring the interspinous space, and then we are interpreting that as to how much foraminal area increase and disc height increase we develop in the human spine. We will eventually, down the road, develop a basic level of force which gives the best clinical outcomes of treating such things as degenerative spondylolisthesis, disc herniation, degenerative scoliosis of the thoracolumbar spine. I think you get the idea. At this time in our certification courses, I'm stressing low force. You can always add to force, but if something goes wrong, you can't take it away. If you look at this chart, therefore, I'd like you to note what 1 pound of distraction looks like. Now, for those of you who are with me, you're going to say, well, Jim, that doesn't look like you're using much. Well, I would say this to you, my colleague. If I take a little piece of dirt laying on my finger, I can't see it or feel it, and I put it in my eye, it feels like a boulder. That's the way I consider this work. So if you look at this chart, we always bring our patient to the barrier of elastic resistance. That means the taut point before we distract the joint. Then we move into the paraphysiological zone, but we don't want to over-distract to where there's a loss of tissue integrity. So it looks like this, VR, L5, manual. I do a lot of my people manually now because I can really control this. Watch the two blue lines. I'm going to bring them, and I want them to be as close to overlapping as possible. When I contact L5, and I bring them to the barrier of elastic resistance, the taut point, you see the two lines elevate? I start from neutral. I bring them to the taut point, the barrier of elastic resistance. That means, at that point, I've taken all of the slack out of the joints below my L5 contact. Then when I apply this force, if you'll look on the right, Julie, I can't see the numbers.
Oh.
Can I see them?
Yep, let me move this over out of the way.
Because I want them to see the numbers. Okay.
They see them.
You see the number there? It says y-axis
Let me get
force.
this up. Put this up. There you go. Y-axis force.
I'm at 10. Look at 1 pound, doctor. Look at how little I move this patient. Some of you may have already learned this. Some of you will soon learn it. That you will get good clinical relief without iatrogenesis when you start at this low force. That's 1 pound. 1 pound. And you're looking at me and you're saying, boy, Jim, I mean, I'm used to doing this. And I say, don't do that. You start again, please. Contact. This force, the Y force, the distraction force are equal to the taut point. I want those two blue lines as close as possible to overlap one another. That means my two forces are equal. Here's 1 pound. Now as this patient begins to respond and says, my pain has went from a 7 to a 6, next time I'll go 2 pounds. Now you can see the increase in the curve on the two blue lines. And if I go to 3 as they respond even better, you see the line increase. Are you seeing that? Are you all okay with that? My point is, doctor, start low. Remembering that we are lowering intradiscal pressure, increasing foraminal area, but also stimulating circulation to carry away these biodegradation products of disc degeneration called cytokines. And oh yes, we need to do studies. I need to do the research study where I treat 100 people and document this. But that means I have to put together the staff, I have to get the IRB approval, and I have to raise the money to do the study. Those are mighty big requirements for one old man. When I make this contact and I move to the taut point, 1 pound, 2 pounds, 3 pounds, 4 pounds, 5 pounds. And while I'm doing this, I say to my patient, Rick, you okay?
Yes.
No pain.
No pain.
What am I looking for? I'm looking for increase in the gemelli obturator internus complex, pain in the retrotrochanteric bursa where the sciatic nerve passes through and is 2 centimeters in breadth. Pain that radiates down the leg. If they feel any of that, I back off on the force. The lowest that I can possibly start with. And then by tolerance testing the patient, how do you feel? I can increase that force. And of course, if I move up to I'm treating, say, an L3, spinal stenosis, I'm going to use a little more force because I've got to open L5, L4 to get to L3. So to get to my taut point, watch how far I have to go to reach the taut point. There it is. Now when I treat 1, 2, you can see the 2 blue lines. 3. Point I want to make to you, doctor, is begin low, begin gentle. Tolerance test the patient every time, and then increase your distraction force by patient tolerance. Now we will be presenting to you through the work of Ted Siciliano some very advanced measurements of force with this instrument. You'll be impressed with it. They're pretty deep, they're pretty heavy, but they will assist you and me in getting the best clinical outcomes in treating our patients. This work is far more than putting someone on a table that just pulls them apart without your attendance. I consider this to be serious conservative care. And why do you need to be serious? Because only 1% to 2% of these low back radicular patients go to surgery. Therefore, we are responsible for 98% of the treatment of back and radicular pain. That's both a beautiful thing and an awesome responsibility. Okay. Now, if I can carry you just one step further. In a patient without full sciatic radiculopathy, or they attain 50%, remember, we're going to begin to move into protocol 2. That we always, first of all, taut point, distract, and then apply lateral flexion under distraction, because we first want to reduce stenosis before we start moving facet joints into the lateral recess and in circumduction. The combination of lateral flexion and flexion and a smooth, rhythmical, coupled pattern. Are there any questions on that, Dave?
Oh, just a couple comments.
Are they good comments?
Yes. You finish doing your thing and then I'll share.
All right. Well, in addition, because this seminar, this webinar, whatever you call it, has been about chemical inflammation, I'd like to point something out to you. When I treat these people, I will use them with automated distraction. I'll set this. You okay, Rick? And I'll just start unattended automated distraction once I've tolerance tested. But in these chemical inflammatory changes that you and I have just studied, I use 2 modalities to help me. One of them is positive galvanic current and tetanizing current. Now, I realize some of you may not use these things, but if we present it to you and you see the clinical outcomes, you may find that you want to use it. So let me just show you. These are pads.
Messed up all your cords. I tried.
And you have positive and negative pads hooked up to this galvanic generator here, okay? Wherever you have chemical inflammation, Julia's gonna use one of these.
That's fine. I thought I was helping. I'm cutting off your head. There you go. Now we can see you.
But wherever we have a disc herniation or a chemical inflammatory change, a high intensity zone, a disc herniation free fragment, a disc herniation, I will put one of these pads right on that inflammatory area. The other one I like to put down on the gemelli obturator internus complex in the retrotrochanteric bursa of the hip. And you know, people complain of a lot of pain there. And then give them 10, 12 minutes of positive galvanism, which drives into that inflammatory area, drives out inflammation and sedates nerves. Now, to get a better idea of that, in my book, we had an instructor at National who teaches physiological therapeutics, wrote the chapter on this. He's much smarter than I am about physiological therapeutics. I know that this helps though. It drives out the inflammatory cytokine inflammation. Then we follow that with a tetanizing current that stimulates muscles like the multifidi, the longissimus, the iliocaustalis, and the gluteus maximus, piriformis, superior and inferior gemelli in the retrotrochanteric space. This helps us to lower the chemical inflammation. People like this so much that they actually say, can I take that machine home with me? So that's one of the things that we do. Did I show that?
Yep, I showed him that was the Amrex unit. So
And the second thing that I urge you to really look into is the use of vitamin B6, 9, 11, and 12. These are the ones that are methylene tetrahydrofolate, B12 to convert homocysteine into methionine. We use curcumin, turmeric root, which is anti-inflammatory, to drive out the inflammation. And we put them on pernicanalicculus, which is chondroitin sulfate from the green lip mussel in Australia, in New Zealand and Australia, in order to regenerate white fibrocartilage. So those are the things that we do in treating these chemical inflammatory agents. I think that we have to leave you with the idea that we deal with two factors, neurocompression and chemical inflammation. Are there any questions?
Got a couple thank yous. So that was good. And Dr. Poulin wanted to be sure to kind of share that Cox Technique and the first table came around in the 60s, and a couple years later, Discat Plus, 50 years ahead of majority of research articles and health and fitness magazines preach now. Cox Technique is decades or a half century ahead of what is accepted as usual or accepted by medical profession. Cox Technique works. Thank you, Dr. Cox, for all you're doing. And
Can I comment on that?
go right ahead.
That was, Dr. Poole was talking about decades ago. I'd like to share with you, and I work with people a lot smarter than I am. I work with PhDs, orthopedists at Kaiser University College of Chiropractic Medicine. And we are doing things now that in the future will be even greater than what we've done in the past, namely ultrasound of spine motion, ultrasound to measure the changes in the spine when we do Cox Technique, and then correlating the amount of force with the best clinical outcome. In other words, how much force should be used. These are things that are being worked on at this time, and I think the future is pretty exciting. Any other thing?
I have one person ask about chronic bilateral leg pain, lumbar spine. What's been your success with it?
Begins with an extreme, as you know, bilateral sciatic pain is unusual, but you're going to break that phylum into two. Are they intermittent down one leg and then the other? Or are they at the same time with the same intensity? If they are bilaterally present, you're going to think of central, huge disc herniation with or without ligamentum flavum thickening up to 8-10 millimeters. If they alternate one leg to the other, and if they're different dermatome distributions, we begin to think of what? Two different discs. I have seen this, not commonly, but I've seen S1 dermatome pain in one leg and L4 in the other. And you'll see people who can't walk on the toe on one foot and on the heel on the other. These people have a permanent deficit. They will never have a normal gait. They will always be pestered with ongoing low back and leg weakness. So yes, I've seen that, but boy, you're gonna correlate careful neurology, dermatome patterns, motor weakness, reflex changes with the MRI. I wonder if that person has that case of bilateral sciatica. You know, that's exciting.
There you go.
But let's say, and I've had these too, let's say you have one leg is F1 and the other one is L4. Contact L3. As long as you stay above the level of stenosis, regardless of the etiology, we're much safer. But you would certainly never want to contact 5 if we had an L4 disc, because you're going to make them worse.
All right. Well, I think you've covered a lot today in your hour and 20 minutes. So I think we better go. Some people I know are going back to treat patients this afternoon. So on your screen, you'll see ways to contact us, email, websites, Cox table information, the AMREX. You can find a link to them. You just go direct to them or through Script Pesco or Austin Medical or something like that to get that unit. If you have any questions after this, just email me. This is Julie. I'll be happy to coordinate answers. And we look forward to seeing you at a live seminar, especially an honors course. That's really where we get into things like that last question about bilateral leg pain. I mean, those kind of things come up in the honors course, and we can really delve into them with great discussion. So hopefully, if you haven't signed up yet for Puerto Rico, come see us in Puerto Rico in February. Look forward to seeing some of you in Florida in a couple weeks for our thoracic course. Thank you for today, and have a great afternoon.